going to be discussing the new classification of periodontal diseases and conditions. I know what you're thinking. The periodontal classification system can be very confusing, and it's really easy to find yourself at a crossroad trying to use your periodontal assessment, your radiographs, and everything to the best of your ability to decide if this patient has periodontitis, or are they healthy, or do they have gingivitis, or are they healthy on a reduced periodontium. Chapter 4 in your periodontics for the dental hygienist textbook is actually just an overview of the new system. We're going to dig a little deeper in this lecture on the details of each category to help you better treatment plan for your patient. So back in 2017, the American Academy of Periodontology and the European Federation of Periodontology came together for one big meeting to completely revise the old periodontal classification system. The old system had not been redone since 1999. So more than 100 experts from all over the world came and completely revamped the periodontal classification and disease categories. So the old system in 99 actually allowed for periodontal conditions to be divided up. For example, a patient could have generalized moderate chronic perio with an area of localized severe periodontitis. So the new classification system introduces the concept of staging and grading based on a full mouth diagnosis. To the patient, you're giving them their stage and grade based on the worst area of their mouth. It's important as dental and dental hygiene providers that we're all on the same page regarding the classification of perio. Though some of this is very subjective, having some basic guidelines will help us communicate our clinical findings to other dental health care providers. So from one office to another, if you're referring your patient to a specialist, if you need this patient to go see a periodontist, for example, knowing the stage and grade based on the criteria of the new system, they should be able to understand exactly what they're looking at with this patient. Being able to properly diagnose and individualize a treatment plan based on your specific patient needs. Predicting treatment outcomes. This is very helpful when we look at the grades of the periodontitis. That basically will give us an idea of how progressive their disease is and the likelihood that they will be losing any additional teeth due to bone loss. And then, of course, for the information that we need to provide dental insurance providers and carriers. For any patient that has dental insurance, this is just a reality of our job. We do have to justify the treatment that we are charging out for the patient. So if you have a patient, for example, that has, let's say, stage 3 periodontitis, grade B, this is something that we would be sending to the dental insurance companies along with their x-rays and their periodontal assessment. The insurance companies need you to justify why you're charging this patient a D4341 or D4342 code. We need to justify that we are indeed providing ethical and honest treatment based on our findings. Here's a general overview of the new classification system. You can see it's broken down into the periodontal health and gingival diseases category, periodontitis, other conditions affecting the periodontium, and PeriImplant diseases and conditions. The 1999 system did not account for the PeriImplantitis at all in the system. Now implants are very common and even placed by general dentists. So this is something you will be seeing more and more in your career. We're going to take a look at each of these categories individually and really dive deeper into exactly what each of these mean and look at some examples. So first we're going to take a look at periodontal health, gingival diseases, and conditions. First we're going to look at health. So periodontal and gingival health. These patients have no bleeding and typically have pink and stippled papilla. The diseased patient with biofilm-induced gingivitis still has no bone loss, but they do have gingival inflammation caused by bacterial plaque buildup. And then we have the non-biofilm-induced gingival diseases. This could be due to the patient having a hormone imbalance or even being pregnant, going through puberty. They may be on medication that's causing some gingival overgrowth. Gingival health. Clinical gingival health on an intact periodontium. If you will notice first by the intraoral camera picture that this patient has no inflammation, has nice pink, stippled, firm gingiva, knife-like papilla interdentally. There's no blunting. This patient, by all accounts, from what we can see in this picture, looks perfectly healthy. You can also see on the radiograph that this patient has no bone loss. You can see where the CEJ is in relation to the crestal bone. So this patient's treatment plan would be the D1110 adult prophylaxis. So one of the more confusing aspects of the new classification system is clinical gingival health on a reduced periodontium. This condition is characterized by no bleeding, no erythema, no edema, no patient symptoms. Everything gingival-wise is clinically healthy. It's broken into two categories. So we have your stable periodontitis patient. This is your patient that has in the past had scaling and root planing and has been undergoing periodontal therapy. And then you have your non-periodontitis patient. So not everyone that has bone loss has a history of periodontal disease. There are other reasons that we're going to take a look at that could reduce a patient's bone level and periodontium around their teeth. First, we're going to take a look at the stable periodontitis patient. So these images show a patient who has periodontal health on a reduced periodontium. This patient has had successful scaling root planing and now has meticulous home care. They've been able to maintain their periodontal status without causing any further damage to the periodontium. So you can see that the radiograph reveals alveolar bone loss. You can see the recession on the facials of the lower anteriors. You can even see recession in this image going back through the mandibular canines, maybe even a little abfraction. When there's abfraction, it leads me to believe that this patient may also be a clincher. You can see the attrition on number 24 and 25 as well. So our treatment goals for this patient would be to maintain the reduced periodontium in a healthy and stable state. We want to prevent the reactivation of periodontitis. So this patient would be on a 3-month periodontal maintenance routine, just so we can maintain the current level of alveolar bone. Now we're going to take a look at the non-periodontitis patient. So this patient has never had scaling root planing. They do not have a history of periodontal disease. What this image shows is a 54-year-old male patient that has a history of excessive and frequent daily brushing. We can see that that is evidenced by the recession that we see pretty generalized throughout the intraoral camera images. I would guess that this patient is also a clincher based on the abfraction that I can see on the upper right and upper left maxillary. Both of these can cause a reduction in the periodontium even though this patient has never had active periodontal disease. So the treatment objectives for this patient would first be to address the oral home care routine. This patient is clearly brushing way too hard and has caused permanent damage. What we can help this patient do is prevent any further damage by showing them how to brush more gently, make sure they're using a soft bristle brush. If they are able, the ideal oral home care routine for this patient would be to be using an electric toothbrush that'll do the work for them and where they wouldn't have to apply any pressure. We want this patient to maintain this periodontium level and not cause any further damage. But since this patient does not have periodontitis, this patient would be treatment planned as the D1110 adult prophy. Biofilm-induced gingivitis is something you will see frequently throughout your career. Gingivitis in itself, if you'll remember from previous lectures, is best described as a bacterial infection of the gingival tissue caused by the plaque biofilm at the gingival margin. It also becomes subgingival as it enters the sulcus and causes the edema and erythema that you see here in this image. Same thing with this patient. You can see the erythema and edema along the gingival margin. And here. So this patient, as far as treatment planning, would be ideal for the D4346 code. We're going to take a look at that in just a second, but let's talk about how we could best care for this patient. If this patient presented to you in clinic, obviously we will see immediately the need for oral home care instruction. This patient has not been brushing properly, as evidenced by the soft deposits that have been there. Most likely, when you remove the soft deposits, you will find the mineralized calculus underneath. You can see how red these images are around the gingival margin. If you are using ultrasonics with this patient, that will remove all the biofilm. If you are not using ultrasonics, then this would be a great patient to actually polish first to remove the soft plaque and then follow up with the hand scalers. You'll save yourself a lot of time and effort in that way, and it's still very effective and efficient. My biggest concern for this patient would be oral home care. Biofilm-induced gingivitis, or gingivitis in general as a condition, also indicates that there is no bone loss with this patient. So remember, on radiographs, this patient will have a healthy bone level within 1 to 2 millimeters from the CEJ. Do you remember what code I said would be appropriate for this patient? So I don't have a periodontal chart here or a gingival description, but as you can imagine, on a periodontal chart with probing, we would most likely see pretty generalized bleeding upon probing. Generalized bleeding upon probing in a patient with gingivitis warrants the D4346 code. This is still a fairly new code, but we do use it here in the clinic, and it would be in your patient's best interest and the best interest of your practice to use this when your patient has generalized moderate to severe gingival inflammation. Remember, that's full mouth, generalized. Also remember, when you are using the D4346 code, you are saying this patient does not have any bone loss. You cannot follow this code with periodontal maintenance every 3 months. If the patient needs periodontal maintenance every 3 months, then the initial treatment planning should involve the scaling and replaning. So the 4346 code is followed up by the D1110. Now let's look specifically at periodontitis. We are going to break apart the necrotizing periodontal diseases, periodontitis, and periodontitis as a manifestation of systemic disease. So one condition we're going to discuss is necrotizing periodontal diseases. First, there's necrotizing gingivitis. This is tissue necrosis that's limited to just the gingival tissue. The patient's going to present with a sudden onset of painful, bleeding, swollen gingival tissue. Necrotizing periodontitis is tissue necrosis of the gingival tissues, but it's combined with attachment and alveolar bone loss. Both of these are very painful, and progression can be extremely rapid and destructive. Next is necrotizing stomatitis. It's severe tissue necrosis that extends beyond the gingiva to other parts of the oral cavity, such as the tongue, cheek, or palate. And you'll learn more about these 3 conditions when you study Chapter 8 in your periodontal class. Now we're going to look at periodontitis. With the new 2017 classification system, there's now 4 stages. We are going to list them here and then take a deeper look at each stage and what that involves. So stage 1 is your initial periodontitis. Stage 2, moderate. Stage 3, severe with potential for additional tooth loss. And stage 4 with severe periodontitis with potential for loss of the entire dentition. Now let's take a look at this chart put out by the American Academy of Periodontology. You can find this graph on perio.org/2017 WWDC. This gives a great layout comparing the staging and grading. You can print this directly from their website, and we also have it available for you in the clinic manual. But let's look at the differences between the 4 stages. First, we're going to take a look at severity. And notice that the 1 to 2 millimeters, 3 to 4, greater than 5, and greater than or equal to 5 on stage 4 is not probe depth, that's interdental cal. It doesn't take into consideration areas of recession. That's not what we're looking at. We're really looking at where the junctional epithelium is in relation to the CEJ. So remember, you may get a 4 or 5 millimeter pocket, but if there's inflammation there, that's really not attachment loss. It's just gingival enlargement. So it's important when you're determining the stage that you're actually going and feeling for the CEJ and subtracting that measurement from the probe depth. So remember, cal is from CEJ to epithelial attachment. Radiographic bone loss. Looking at the bite wing and PAs are extremely helpful in determining where the crestal bone is in relation to the CEJ and apex. So if it's still in the top coronal third and we have less than 15% bone loss, the patient's going to be stage 1. If it's in the coronal third between 15 and 33%, it's going to be stage 2. Notice both of those stages, the patient has had no tooth loss due to periodontitis. Stages 3 and 4, the cal is the same and the radiographic bone loss is the same. The biggest difference is how many teeth the patient has lost due to periodontitis. So we want to look at counting the teeth and then looking at the complexity of this individual's patient's periodontal status. So when we look at stage 3 and 4's complexity, notice that probe depths are equal to greater than 6, and they have vertical bone loss. With stages 1 and 2, it's mostly horizontal, and there's no furcation involvement. In stage 3, we have furcation involvement, class 1 or 2. Severity, they may have moderate ridge defects as well. In stage 4, it's everything that stage 3 involves. In addition, the patient may have greater than a stage 2 mobility. They've lost equal to or more than 5 teeth. They may have less than 20 teeth remaining in the arch. Then you're going to describe to which extent. So remember, when we're coming up with the classification for staging, we are choosing the most severe area and giving the patient that stage. So staging and grading has been used in oncology for years, and with this new classification system has just been introduced into dentistry. But patients are pretty familiar with this type of terminology in regards to their health. So remember, with this classification system, we are given the patient their stage based on the worst area. So you may have a patient who's overall healthy, but has a localized area of 2 millimeters of clinical attachment loss, and they have some radiographic bone loss. Probe depths are around 4 millimeters in that area, and they just exhibit a little bit of horizontal bone loss. You're not going to call that patient healthy. You're going to let that patient know they have localized stage 1 periodontitis. If it is generalized, being more than 30% of the teeth involved, then you would tell the patient they have generalized stage 1 or 2, whatever stage they have, periodontitis. So that's how this staging works. It's pretty black and white as far as what we're looking for in regards to clinical attachment loss. And again, the PAs are very helpful in determining the radiographic bone loss, measuring from the CEJ to the apices. You can basically divide the tooth into thirds and calculate where the bone level is. Now we're going to take a look at grading. Again, this chart is just the second half of the first one, and it is available to you on perio.org. So you have access to this information anytime you need it. When we give our patients a grade of their periodontal status, we are giving them a level of expectation on how fast we think their periodontitis is going to progress. So if your patient had successful scaling and root planing and has been maintaining their periodontal maintenance appointments, they're a non-smoker, they come in and we're really kind of maintaining their level of bone loss, then they're going to be grade A. We don't expect for this patient to come back in 3 months or 6 months for their periodontal maintenance, and we see a great progression in their periodontal disease. A grade B patient would be one that you are finding evidence of moderate progression with their periodontal disease, and they may be a smoker, smoking less than a half pack a day, or a diabetic patient whose A1C is less than 7%. Remember that smoking is one of the biggest risk factors for periodontitis, and that uncontrolled diabetes and periodontitis go hand in hand. Their relationship is bidirectional, and our patients that have uncontrolled diabetes are at a greater risk for uncontrolled periodontitis. A grade C periodontitis patient is one that we see the destruction happening at a more rapid rate. So they have had greater than or equal to 2 millimeters of bone loss over the last 5 years, or they smoke more than a half pack a day, or they're diabetic patients whose A1C is greater than 7%. So any patient who is smoking more than a half pack a day or has uncontrolled diabetes is automatically going to be considered a grade C. Their periodontitis is going to progress much more rapidly than a patient that does not have these modifiable risk factors. So how would you know on this patient if this patient has stage 1 periodontitis or if they have healthy gingiva? Because the bone level is going to be very close to the stain. So if they have active periodontitis, the x-rays alone will not give us the full picture. We really need to see the full periodontal assessment to see if there was any bleeding upon probing, if we have any causative factors causing some inflammation, or any further tissue destruction, not just what we see on the radiograph. Stage 2 periodontal disease. Here's a sample perio chart of a patient who has been classified as having stage 2 perio. You'll notice the probe depths do range between 4, 5, and 6 in the posterior region, but remember that we do not have you guys subtracting gingival margin to CEJ, and true clinical detachment loss is from CEJ to junctional epithelium. That's why the radiographs are so important in helping us with our overall classification of their periodontal condition. So let's look at a couple bite wings. Obviously, we have a full FMX on this patient in the clinic, but when we look, we can see areas of vertical bone loss from here to here, even a little bit up here on the upper right. Even over here on the mandibular premolar, we can see bone loss, but it still falls within 15 to 33% area on this patient. This patient's treatment plan would be 4 quads of D4341 scaling and root planing with a follow-up periodontal evaluation, followed by every 3 months the D4910 periodontal maintenance appointments. Now, this patient will always be stage 2. However, we can get them to a state where they no longer have periodontitis. There's no more bleeding, no more inflammation, as long as we can have the patient get rid of any modifiable factors they may have, if this patient's a smoker, if this patient has uncontrolled diabetes, and get them on a good oral home care routine where they're taking good care of their oral health. Stage 3 periodontitis. There's an x-ray of a patient in our clinic who has been diagnosed with stage 3 generalized periodontitis. This patient, as you can see, has lost more than a third of the crestal bone. This patient would have been a good patient for vertical bite wings. You can see here on the anterior PA where the CEJ is on these incisors in comparison to where the alveolar bone is. So you can tell that it's almost halfway between CEJ and apices. And here's a sample pro chart. If you'll notice on this patient, there's actually less bleeding than on the patient that we just saw that was stage 2. Stage 4 periodontitis. Remember, most of the descriptors for stage 3 and stage 4 are very similar. The biggest difference in these two would be that in stage 4, this patient has lost more teeth or has the potential to lose more teeth due to their periodontal state. You notice here on the incisor that there is a lot of bone loss, advanced bone loss into the apical third. This patient on that tooth actually had stage 2 mobility as well, as you can see on the periodontal charting. This patient had severe inflammation, chronic bleeding, furcation involvement, and there is a good likelihood that this patient will be losing more teeth due to severe bone loss. Grading of periodontitis. So grade A, grade B, and grade C we looked at in the chart. This will just be an overview. We have grade A, which is the slow rate of disease progression. Grade B is moderate, and grade C is very rapid. Remember, if they smoke more than a half a pack a day, or if they have uncontrolled diabetes, they're going to automatically be a grade C. Other conditions affecting the periodontium. We're going to take a look at these 5 other conditions individually. First, there's systemic diseases or conditions that affect the periodontal supporting tissues. Some examples of this would be diabetes mellitus, especially if it is uncontrolled, stress, hormones due to pregnancy, puberty, or even menopause, HIV, neutropenia, Down syndrome, and leukemia. The image you see here is a pyogenic granuloma on a pregnant patient. Periodontal abscesses and endodontic lesions. Radiographically, you see an abscess is this radiolucent area around the apices. In this case, with this radiograph, you can see that this patient has had endodontic treatment on this tooth. In the intraoral camera picture, you can see the textbook swelling of the abscess. If we were to see this on radiograph, you would also see the radiolucency around the root surface of, around the apices of number 30. Mucogingival deformities and conditions that your patient may have could be recession, which we see very frequently with our hard brushers. Gingival enlargement, this could be due to a medication that's causing the enlargement or a factor such as orthodontics. This patient exhibits gingival enlargement that is typical of medication Dilantin that can cause gingival overgrowth. Traumatic occlusal forces can cause loss of periodontium. That does not mean the patient has periodontal disease. It's just a condition that is reducing the periodontium due to the occlusal force. So this is our clinchers and our grinders. You can see in the picture pretty textbook abfraction that we see in our clinchers. Radiographically, we would see a loss of crestal bone, but these patients do not have periodontal disease, so they may have health on a reduced periodontium. You can see in this picture that there's no inflammation. I don't have a probe chart on them, but given the appearance, it would look like there may be little to no bleeding upon probing with this particular patient. Tooth and prosthetic related factors that affect the periodontium. Orthodontics. Not only could a patient have reactions to the orthodontics and cause the gingival overgrowth, but orthodontics, due to the natural movement of the teeth, there's the resorption of bone. If the teeth are moved too fast, the patient may lose some crestal bone. Again, the patient does not have periodontal disease, so this would be health on a reduced periodontium. It's due to the orthodontic treatment. This extracted tooth has an enamel pearl. That's a tooth-related factor that could cause some localized loss of periodontium in that area. And then we have prosthetics. So this patient has had a tooth pulled. Don't know if that's due to periodontal disease or was not able to be restored. Looking at the bone level, this patient does probably have at least stage 1, if not stage 2, periodontitis. However, these prosthetics are very difficult to keep clean, so this is an increased risk factor for this patient to have further destruction of the alveolar bone. PeriImplant diseases and conditions. You will learn more in depth about these conditions and diseases when you study Chapter 9 in your periodontal textbook. However, we're just going to take a quick look at these four. The 1999 classification system did not account for implant diseases at all. This was a big reason that that system needed to be updated. First, we're going to look at PeriImplant Health. You can see in this radiograph that the bone has nicely osseointegrated around this titanium implant. Bone level looks good. Gingivally, we don't have an IOC picture. However, we can tell by the bone level looking healthy that this implant appears to be stable. PeriImplant Mucositis is basically gingivitis around the implant. It's typically plaque or biofilm induced. The soft tissues are inflamed, but there's no loss of supporting bone. It's typically just localized around the mucosal tissues that surround the implant. It is reversible if the etiologic factors are removed. So it may progress to PeriImplantitis if the patient's oral home care does not improve. PeriImplant Mucositis is diagnosed just with a visual and periodontal assessment. Obviously, you can see the inflammation, but the patient would also, upon probing, have bleeding, and obviously you can see the erythema and edema. And PeriImplantitis is essentially chronic periodontitis affecting the hard and soft tissues surrounding an already functioning osseo-integrated dental implant. PeriImplant soft and hard tissue deficiencies. So following tooth loss, bone resorption is just naturally going to take place. And so sometimes that'll result in hard tissue deficiency. Some patients actually require some implanted bone before they can have an implant placed. You'll learn more about this in Chapter 9 as well. Another common deficiency with implants is soft tissue recession. So as you can see in this picture, the gingival margin has receded and you can actually see the implant post. This could be due to the implant being malpositioned or just lack of buccal bone or that tissue being really thin in that area. I hope that this video helped clarify this a little bit on staging and grading. I know it can be super confusing. It can be a little bit subjective. It's going to vary from office to office as far as their protocol regarding treatment planning. You will learn more about the staging and grading as we go through this semester and also next semester in your periodontal disease class. Right now, we just needed a basic overview. Please feel free to email or ask us questions in clinic, and always remember to use your clinic manual.